mortality rate, especially here in Ohio. So when we talk about infant mortality, what we're really referring to is when a baby who is born alive dies before its first birthday. So infant mortality is a baby that is born alive but does not live past his or her first year of life. And at the population level, we look at what we call infant mortality rates. And this is, on average, how many babies die before their first birthday for every 1,000 babies who are born alive within that population. So you can see here at the United States, we actually rank low, very low on this metric compared to other industrialized nations. We, on average, have about 6 babies who are dying for every 1,000 babies who are born alive. And if you look at some other countries like Finland and Japan, their numbers are about 2. So we really do suffer higher rates of infant mortality in our nation compared to many other nations that maybe have a similar economic background as we do. Unfortunately, here in Ohio, our rates are even higher. So remember that national average was about 6 babies for every 1,000 babies born alive. Here in Ohio, the most recent data that we have from 2015 is that about 7 babies die for every 1,000 babies who are born alive. And we also see what we refer to as a disparity. And a disparity is whenever you see a difference in health status or health outcomes between 2 populations. Those populations can be maybe 2 different races and ethnicities, they might be 2 different geographic locations. So you see that here in Ohio, we actually have a great disparity when it comes to the number of babies who die for white mothers versus African American mothers. We can see that the rate for African American babies is over 15 for every 1,000 babies who are born alive. And that actually puts us at just about the bottom of the nation. We are 49th, 50th when it comes to infant mortality compared to all states in the nation. So in Ohio, we've established some pretty aggressive goals to try to improve our infant mortality rate. Our goal is that by 2020, we would be able to drop the infant mortality rate, try to close some of the gap that we currently see in this health disparity. And nationally, we have a goal. Every 10 years, our national government, the Department of Health and Human Services, publishes what they call Healthy People. And it's basically health-related goals for our nation for the next 10 years. So the Healthy People goal is that by 2020, our infant mortality rate would be 6. So you can see that here in Ohio, we're pushing pretty aggressively. We're hoping that even our overall goal would be lower than the national average. So when we think about what's really driving the infant mortality, it's important to consider what are the main causes of infant death, because if we can know what those causes are, then we can be designing some interventions, hopefully, to prevent those deaths from occurring. So you can see here, about 47% of our infant mortality here in Ohio is due to babies being born too early or too small for their gestational age. We also see about 14% of those deaths are due to birth defects. About 15% are sleep-related deaths, and this could be babies that suffocate, maybe have sudden infant death syndrome known as SIDS, or with those sleep-related deaths, many times there are undetermined causes. It's not really known why the baby passed away in his or her sleep. And then we have other causes, about 25% of just other assorted reasons why we see infant mortality in our state. So there has been a lot of statewide attention on this infant mortality issue, especially in the last several years. There's been a lot of initiatives to try to reduce the infant mortality rate. And really at a statewide level, in 2009 is the first time that an actual task force was established to look at the issue of infant mortality and come up with some recommendations. From that grew the Ohio Collaborative to Prevent Infant Mortality. This is a group, it's a statewide group of volunteers who are interested in infant mortality. I'm a member, anyone can be a member. It represents, clinicians as well as insurance companies, Medicaid programs, policymakers. Usually we have state representatives speaking at our meetings. So it's really just a large consortium of people across the state who are interested in this issue. And then every other year since 2012, we've been hosting statewide infant mortality summits, which is a chance for people to come all across the state in one place. We've had about 2,000 people at the last 2 infant mortality summits that we've had. We have some plenary speakers and some breakout sessions. Again, a wide variety of people come to this conference, community members as well as those in the scientific community. And something that always really stands out to me is at these summits, they invite families who've experienced a loss to come share their story with everyone there. And it always makes you even recommit again to the work that you're doing and hopefully try to help reduce this infant mortality rate. So because I am a pharmacist, I do think that pharmacists have really a great opportunity to help with this infant mortality rate because of our accessibility. If you think about a community pharmacist, highly accessible to the public, able to answer questions. Most Americans live within 5 miles of a community pharmacy. People are typically seeing their pharmacist more often than they're seeing their doctor in any given year. Also, pharmacists have a lot of knowledge and expertise and ways that we could be educating our patients and working with them. So when I think about it, I think about 3 main time periods that we could be helping families prevent infant mortality. The first is what's known as the preconception period, and that's before pregnancy even occurs. There's things we can be doing in that time period to help have a healthier pregnancy. Of course, during pregnancy and then after pregnancy, that postpartum period, or even what's called the interconception period in between 2 pregnancies, are other times that we can make a difference. So what are some things that I think pharmacists can be doing at these times? Oh, I guess this doesn't show it very well in this. Basically, I tried to split it out, so you would see it one phase at a time. But basically, everything from helping with family planning to managing disease states for mothers, to helping educate families on how to properly give medication to their infants, because sometimes unintentional overdoses occur. People think that a children's formulation of a medication is safe for an infant when that is not the case, or they don't know how to dose the medication appropriately. So there's many different ways that we can have an impact, but there's 3 in particular that I want to briefly touch on, and these are folic acid, vaccines, and medications that could cause fetal harm. So first of all, folic acid. Folic acid is a B vitamin, and the reason folic acid is so important is that it can prevent a very serious birth defect known as a neural tube defect. And neural tube defects can include things like spina bifida, which are serious birth defects of the spine, which can result in paralysis, or another fatal birth defect known as anencephaly, where actually the baby develops but without a brain. So these are very, very serious traumatic birth defects for the family. So by taking this B vitamin in adequate levels, we can reduce the risk of this birth defect actually occurring. The challenge is folic acid has to be in a sufficient level in the body before conception and in the very first few weeks of pregnancy, because the neural tube, or what becomes the spinal cord, closes within 28 days of pregnancy being established. So many times a woman may not even realize she's pregnant at that point and misses out on the opportunity to take this folic acid. So here in Ohio, we see that only about 30% of women report taking folic acid, which is commonly found in multivitamins, before her pregnancy. And we see disparities where only about 19% of women who are under the age of 24 and only about 20% of African American women report this health behavior. So the recommendation is that all women, regardless of whether they're actively planning to become pregnant or not, should take folic acid. And although it's available in food, it's hard to get enough through food sources alone. So it's recommended that everyone take a multivitamin. And that's where pharmacists can really play a role in educating patients when they come to the pharmacy to let them know that they need their folic acid. Another example are medications that can cause fetal harm. And we have certain medications that we know should absolutely not be used during pregnancy because it could cause fetal death or could cause very serious types of birth defects. The challenge is about 90% of women take at least one medication during pregnancy, and the use of multiple medications during pregnancy, that practice has doubled in the last 30 years. So pharmacists really, I think, are ideally positioned as the drug expert. We know which drugs may cause the birth defects, may cause the problems, and so we can help patients. We can help maybe minimize exposure to these meds, maybe change to a medication that might cause less fetal harm, maybe lower the dose, try different strategies to try to minimize that exposure. The third intervention I'm going to briefly talk about is vaccines. And it's really important that women receive necessary vaccines both before and during pregnancy to protect the developing baby, because there's certain diseases that if a woman catches them while she's pregnant, it increases the risk of a birth defect. So rubella or varicella cause birth defects if women contract those diseases while pregnant. There's some diseases like hepatitis that can be spread from the mother to the child. And then there are diseases that the infant, if the infant would acquire them, like influenza or pertussis, which is known as whooping cough, could really be fatal to that small child. The challenge is that most adults are not routinely receiving the vaccines that they need. And here in Ohio, pharmacists are able to vaccinate adults. So this is a service that we can provide and help patients with. So because I feel so strongly that pharmacists really could play a role and close the gap for some of these needs for patients in Ohio, I had the opportunity to collaborate with some other individuals, as well as a Medicaid plan and a company that does documentation, a software company. And we came up with a demonstration project here in Ohio to see how does it really work, pharmacists trying to make an impact on these elements of infant mortality. And so we developed a program for community pharmacists, and we focused on those 3 interventions that I mentioned to you. And basically, the project launched in November 2015. How it basically worked is the Medicaid plan knew patients who would be eligible to receive these different interventions. So for example, a woman of childbearing age who is receiving a medication that we know could be potentially harmful if she were to become pregnant. A notification was sent to the community pharmacy electronically that there was a patient that needed this service. The patient or the pharmacist would attempt to contact the patient, deliver that education, and then document for that service. What we found is that 62 weeks, so just a little over a year and a little month or 2 after we launched the program, we had over 2,000 different pharmacists and over 1,000 different pharmacies across the state be involved in this project, and they were able to successfully deliver over 20,000 different educational interventions with patients. So I think we showed that it's scalable. I think we showed that pharmacists felt comfortable having these types of conversations. Patients were willing to have a pharmacist talk to them about these different health behaviors that they need to do before they even become pregnant. So this has served as the basis of some additional projects and kind of some next steps of the project that we're trying to further develop. So pharmacists are just one piece of the puzzle. There's a lot of other initiatives going on all across the state to try to impact infant mortality. There's over 25 different interventions that are being currently funded by our state government. I highlighted just a few here for you. One, for example, focuses on what's called neonatal abstinence syndrome. This is basically an issue that occurs for babies whose mothers abused certain types of drugs while pregnant, and so these babies are in effect born addicted to these drugs and will go through a withdrawal period once they're born. And there's been different, studies and interventions looking at what's the ideal way to help these babies. Looking at things like fetal infant mortality review, because if we can better capture the cases of infant death and analyze them, we could maybe look for additional clues of things that went wrong, and again, that could maybe lead to additional preventative measures or additional educational or awareness measures. So just a smattering of the over 25 different interventions that are currently ongoing. I wanted to make you aware of one initiative that anyone can be a member of. If you're interested, you can volunteer. It's called Our Babies Count, and I put the website here for you. Basically, this is a group across the state. Again, many different types of folks are involved in this organization, but their goal is to raise awareness about infant mortality in our state, to provide resources. They do a lot of home visits. They do a lot of education, and again, it's oftentimes other community members providing that education. It's not necessarily someone with a medical or a scientific background. And so they are trying to raise awareness that this is a website that people can refer to if they want information about a healthy pregnancy. Their main focus is trying to reduce those rates of premature births that we saw as one of our largest drivers of infant mortality. So if you're interested, I think this would be a great place to start getting some more information and also looking at ways to volunteer. So I'll just leave you with a quote that I find very inspiring. I believe that investing in our children's development from the earliest age is the single most important contribution we can make to the health and well-being of our citizens, their capacity, and the future prosperity of our state. And with that, I'll take any questions that you may have. Yes?
Is there any differentiation between mothers who receive prenatal care and those who didn't as to whether or not they had higher infant mortality rates?
Yeah, that's a really great question. So the question is about whether or not prenatal care makes an impact with infant mortality rates. And kind of the rule of thumb is that, it's kind of a saying in this field, you can't cure a lifetime of ills in 9 months. So while, of course, there's some really important interventions that we can give during prenatal care, many times, number one, women enter prenatal care too late. They may already be pregnant when there's a lot of things we need to be doing before the pregnancy, like folic acid and some of the vaccines to prevent birth defects. But also, secondly, if a woman enters prenatal care in a health state, maybe, for example, diabetes that isn't well controlled, high blood pressure that isn't well controlled, there's not too much we can do in that prenatal period to help the mom as much as we could have if we could have managed her disease states before she even became pregnant. So, I mean, definitely it helps, but definitely the impact is not as significant.
Prematurity might have been alleviated had there been prenatal care, or was that borne out within the data set to know, okay, we saw higher rates because they didn't get prenatal care at all?
That's a great question. I haven't quite seen it exactly linked, looking at if the rates of prematurity were different here in Ohio specifically based on whether or not women received prenatal care. In some ways, there's a lot of confounding factors as to who might be getting the preconception care, if they're healthier or not healthier to start with, and also some interventions that if those women are at least in prenatal care, we can do hopefully some interventions. For example, there's been a big push for a certain type of injection that you can give to women to help delay pregnancy from occurring, but there's a lot of issues around how expensive this medication is and access to this medication. So sometimes if someone's even in prenatal care, they may not still have the access to the services that they would really need to make a difference for them. I don't know if that's fully answering your question, but there's no clear line that I've seen. Yeah.
One of the things on yes, that one, birth registry accuracy project. What is that talking about?
Well, trying to make sure that we have an accurate picture of all the births that are happening in our state and getting more complete information on the birth certificate, because I have done projects in the past looking at birth certificate data, and you would be surprised perhaps at how incomplete it often is. And if we had better information about the birth, any complications that occurred, but also the health status of the mother and father, which there's spots for that on that birth certificate. Again, it would help us better understand some of these underlying causes potentially. Yes?
I've heard you quote a statistic that 50% of the births are unplanned.
Yes.
Do you have any sense of the challenges that we see with infant mortality being associated more with the unplanned versus the planned pregnancies?
Yeah, that's a really great question. So as Dean Martin alluded to, in the United States, we actually have really high rates of unplanned pregnancies. About 45% of all pregnancies in our country, though the mother will report that she did not intend or plan to have the pregnancy at that point in time, and that makes it really challenging for a lot of these preconception recommendations that we want to do with individuals before they even become pregnant. So again, in regards to infant mortality, I think that is definitely one of the drivers there. I don't think it's any surprise we have the highest rates of unintended pregnancies and the highest rates of infant mortality compared to many other industrialized nations. So that definitely is a potential driver, because again, there's a lot of exposures like medications or even substance abuse, alcohol, smoking, as well as better management of disease states, that if a woman's planning a pregnancy, we can be proactively working on those issues before she conceives. Yes?
On your pie chart, you have the 25% that's other.
Yes.
Can you give us a general idea of what those other include?
Yeah, so on the pie chart, 25% of infant mortality cases in Ohio have other causes of death. One of the ones that I know of that is one of the larger segments of that 25% are unintentional injuries or accidents that occur. Others can be other diseases that occur, for example, deaths due to the influenza or pertussis that I mentioned. So, there's not, within that 25% are also basically infectious diseases. Well, thank you very much for your attention. I really